acknowledge and pay tribute to the traditional territories of the peoples of Treaty 7, located in the heart of southern Alberta, which includes the Blackfoot Confederacy, comprised of the Siksika, Piikani, and Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6. We would also like to acknowledge that the University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Cree, Blackfoot, Stoney, Iroquois, and Ojibwe lands that are now known as part of Treaty 6, 7, and 8 and homeland of the Métis. The University of Alberta respects the sovereignty, lands, history, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. Before we start our seminar, we also like to emphasize that we encourage a brave space for open and honest dialogue, active listening, respect for diversity and inclusivity. With that being said, we will be recording the seminar, but for the discussion for the audience, we'll be turning that off, so anyone can feel free to ask their questions or even drop them in the chat. I will start by introducing both our speakers. We have Dr. Elena Lopatina, who is the senior scientist with the Alberta Virtual Pain Program at Primary Care Alberta, and also an adjunct assistant professor in the Department of Community Health Sciences at the Cummings School of Medicine. She's a health services and policy researcher specializing in the design, implementation, and evaluation of complex health system innovations. As a senior scientist with the Alberta Virtual Pain Program, she leads an embedded research program focused on transforming chronic pain in Alberta through digitally enabled, team-based, and virtual models of care, and provides scientific leadership for Canada's first province-wide publicly funded virtual chronic pain program, supporting the development of a provincial learning health system for pain management. She's also a co-chair of the Alberta Pain Strategy and is involved in various initiatives advocating for evidence-based improvements in pain management in Alberta and across Canada. And also Dr. Lisa Jasper. She's an adjunct professor at the Faculty of Rehabilitation Medicine at the University of Alberta, where she coordinates the graduate certificate in pain management and teaches in the graduate programs. She holds bachelor's degrees in chemistry, physiotherapy, a master's in chronic pain, and a PhD in rehabilitation science, with research in chronic pain, physical activity in older adults, and hip, knee osteoarthritis. Other research interests include pain education, rheumatoid arthritis, and whiplash-associated disorders. She has worked clinically in both rural multidisciplinary clinics and chronic pain clinics. She's a member of the Pain Society of Alberta, Canadian Pain Society, Canadian Physiotherapy Association, and World Physiotherapy, and the International Association for the Study of Pain. She brings expertise in online and hybrid learning to teaching, coupled with a dedication to share current evidence-based information on the management of pain to both healthcare providers and people living with pain. With that, we'll get started. Thank you very much, both of our speakers, for joining us today.
Perfect. Thanks for the introductions, Margaret. So as mentioned, it'll be a panel discussion. So I'll be posing questions to both of our speakers, and then we'll allow time to respond and just move forward with the discussion like that. Again, at the very end, we'll have time where we'll stop the recording, and if people would like to ask further questions, feel free to do so. So we'll start with our first question. So we were wondering if you could please introduce yourself and your connection with rural care, specifically in regard to pain care.
I'm happy to start. I'm a senior scientist with the Alberta Virtual Pain Program, and Alberta Virtual Pain Program, AVPP, is a provincial program that provides access to patients to chronic pain management, multidisciplinary team care that is delivered in virtual settings and allows patients to receive high quality care and pain management regardless of where they are. So the goal of the Alberta Virtual Pain Program is to meet patients where they are and make it accessible for them. And people living with chronic pain experience particular barriers to care, but we know that those living in rural areas and in remote settings often experience even larger barriers. And this is why Alberta Virtual Pain Program is there and to meet patients and provide that care that would be accessible for them regardless of where they are.
Thank you so
Thank
much.
you.
We'll head over to Dr. Jasper.
Excellent. So thank you very much for the kind introduction, and hello, everyone. I guess my background is a real mixture of clinical practice, teaching, and research, but rural healthcare is definitely consistent throughout it all. As you mentioned, I did start my career as a physiotherapist, working in my multidisciplinary private practices, which were all in rural communities. And that's where I started to really understand what rural everyday challenges and rewards look like. And I've almost always lived in rural areas or small cities. So rural life and advantages are certainly very familiar with me. Very early in my clinical practice, actually, I started being really curious about the patients that weren't getting better. And I want to understand more about that. And I was very frustrated about the resources we had. And I think that's a common trajectory that people have. So that curiosity did lead me back to school. I completed my research master's, as you said, and later my PhD. As you mentioned, currently I do coordinate the Faculty of Rehab Med's Graduate Certificate in Pain Management. I started at U of A in 2011, and I did spend 10 years at the Physiotherapy Rural Satellite Campus, coordinating Augustana. And that's also where I just gained a real appreciation for distributed virtual and online learning, and of course, rural health education and healthcare too. And as you said, some of my current research interests do include research into the delivery of healthcare education in a rural setting, of course, promoting healthcare providers to work rurally, and research into the delivery of virtual self-management education exercise programs. So not dissimilar to the fabulous virtual pain program that Elena was talking about. And then research into access to care, which I do think is especially relevant when we're talking about pain care in rural settings, because there certainly are some unique challenges there, as we know. So I guess overall, my connection to rural pain care really comes from living with it, working with it, teaching in it, and of course, just trying to improve access to it as well. So excited to be here.
Awesome. We're excited to have you. Thank you so much, both of you, for that introduction. Super cool to see how interdisciplinary both of your fields are and how rural care is streamed throughout that. Our next question kind of goes off of that. What type of barriers do you see for rural patients, and how has the work that you've done mitigate this? And kind of like, I guess a follow-up question might be if there are any specific demographics affected most to rural care.
Do you want me to go, Elena? All right. So lots of ways to answer that. In terms of the types of barriers seen for rural patients, many of the barriers rural patients experience, I think, are the very same barriers we see across healthcare systems more broadly. So access to providers, wait times, travel, navigating complex systems, et cetera, which we all know about. But I do think these challenges are definitely amplified in rural settings, and then even more so for people living with chronic pain, as well. We all know that's so common, 1 in 5 people. And I do think there's been tremendous advances in our understanding of pain over the last decade, but that knowledge does take time to disseminate and be implemented in practice. And I do think that's one of the ongoing challenges or barriers to care is that both healthcare providers and people living with pain don't yet have a really good understanding of, the neuroscience and what's actually happening with chronic pain and how that can affect management. Another barrier is certainly healthcare providers staying current with this evolving knowledge is difficult, especially for those with general caseloads who can't stay current for absolutely everything. And for people living with chronic pain, it can be really hard to access reliable information and effective care, especially in rural areas where there's might be fewer providers. So some of the work that we've done, or some examples have been where we've tried to address some of these barriers. I can go over just a couple here. The first is increasing the rural healthcare workforce. For example, in 2024, we published results of surveys, focus groups, and employment data for students that did train in the rural physiotherapy satellite campus at Augustana. And we were really excited to see that students trained in the rural campus were actually much more likely to work in rural communities. And in fact, it was about 74% of graduates from that campus reported securing their first position in a rural location. And that was even, they didn't have to come from a rural background or indicate any interest going into the program. So there wasn't any prior biases there. And of course, that's kind of consistent with what other people find too, that exposure to rural settings can help recruitment. And this program also showed that students felt strongly connected to their peers and instructors, despite the distributing learning model. So I think that can really help reinforce that it is possible to have these virtual relationships too. I guess another area I'm really excited about is just the knowledge dissemination, as you said, my interest in that. So making sure both healthcare providers and people living with chronic pain have access to that reliable, practical information. So we did start the U of A graduate certificate in pain management in 2010. So long before COVID and long before people were doing as much online. And these are fully online interprofessional courses. So healthcare providers can access that evidence-based interprofessional education and really work with each other wherever they are. So we have looked at some research into that, and we explored the demographics and some feedback from the first 12 years of the program. And we've had participants from many provinces and actually quite a few countries as well, and a wide range of professions. I think we've had 11 different disciplines, and almost every course we have at least 5 or 6 different disciplines, which I find exciting. I think it's one of the strongest parts of it. And some of the sort of strongest themes in feedback have been an online and flexible format does make it possible for clinicians, often rural, to participate. And so we've just introduced a shorter introductory micro course to that too. So I think that can help mitigate some of the isolation and some of the challenges in education. Something else we're looking at is just how we can deliver care a little bit differently. And for example, in our recent Ready at Home study, we did just a feasibility study looking at virtual self-management, education, and exercise programs for people living in rural communities, only rural, with pain limitations due to OA. And even though many participants had never used online programs before, it was often grandchildren that were setting up the Zoom calls and so forth. We did have our retention rates over 90%, and satisfaction was really high too. So we were very excited about that. And it wasn't necessarily the people that thought they were going to enjoy it that did get some benefit from it too. So that was encouraging. And then our qualitative work in that showed that really we were able to develop those meaningful patient-therapist relationships through this virtual platform, even though people were often quite skeptical. And then we're actually just doing RCT now through that program, similar to that program, comparing usual care and then the virtual individual and group classes. And actually, we're still recruiting. If anyone knows that, if anyone that may be interested in free physio and are living with pain. And then I guess the last thing, kind of our current research, is that some of our research has looked more broadly at how people access care and all the different factors that affect that. So we've extended the candidacy model of healthcare to better understand the different steps that people go through when accessing care. So things like identifying a need for care, navigating the system, being assessed by providers, receiving and navigating offers of care, like what does that look like, as well as, of course, local healthcare context that influence all these dimensions too. So while the barriers are real, I do think absolutely there's many reasons to be hopeful. And as we were talking about too, I think there's lots of new programs such as the virtual pain program and these ones too that are really quite encouraging to help address some of the challenges.
Thank you so much for the really thoughtful answer. And yeah, you mentioned a lot of really prominent barriers, but it's really exciting to see the steps that you're taking forwards to address these, and seems really promising. So thank you so much. We can pass it over to Dr. Lopatina.
Yes, thank you. I think Liz already mentioned quite a few barriers that patients experience, and I agree that often barriers are the same that patients experience in urban settings, but they might be amplified and become more challenging for patients living in the rural areas. And just to add to that, I think additional layer of that challenge and complexity is the variability and inconsistency of services and care that is available for patients across Alberta in general, but in particular in rural and remote areas. We did a survey of chronic pain programs back in 2023, I think, and asked chronic pain programs as well as primary care networks about what chronic pain services do you provide. And we found that first of all, there is very few that actually offer that support, but also they're very inconsistent across the province, with the majority located in urban centers. The tertiary centers are located only in urban centers. So as a result, it's really hard to navigate that system, even for providers, but also for patients. And it's really hard to get there. And especially for patients living with chronic pain who have limited capacity often to do that travel, it is often a challenge. And we also did a patient-to-patient research that was led by patient and community engagement researchers from the University of Calgary, trying to understand that journey that patients go through after starting having chronic pain. And the findings are very consistent with what we see from the service availability. Patients feel lost. It's hard to find any resources. It's hard to navigate that system. They feel lost. They feel unsupported. They feel unheard. And it's often devastating what patients actually have to go through. So all those findings actually informed the design and development of the Alberta Virtual Pain Program. And the whole idea of the program is to make that care accessible regardless of where patients are. And what we see with the participants is that over 50% of them are coming from outside of Calgary and Edmonton HS zones, which I think is a testament to the ability to reach populations outside of the urban settings. And also we get qualitative feedback where patients say that it's so hard to find those resources. And we see from the data that we collect that most of our patients have lived with chronic pain for 10 plus years, and they're still seeking help and support, and unfortunately have gone through so many barriers and so many challenges to receive that care. And we hear a lot from patients living in rural areas that they feel isolated and they feel alone. They don't get that support. So having access to that support through the virtual pain program is very helpful. And we've received over 90% satisfaction with our participants, as well as clinically and statistically significant improvements in patient outcomes, which I think is very important, that patients finally find some care. It's just unfortunate that they have to wait often for 10 years to find that care. Another point to add, we received a patient experience award from the Health Quality of Alberta, Health Quality Alberta, which I think is another testament of the need for that support. How big is the gap? How large is the need for chronic pain care? And that hopefully now there are some resources, including Alberta Virtual Pain Program, including the programs that are studied at the University of Alberta, that start addressing those gaps and those needs.
Thank you so much. Yeah, you raise a lot of great points as well. And yeah, it's very surprising for something so prevalent in our society that we are just now starting to build these virtual options for people. But obviously both of your work has had a huge impact on people already. So that's really promising. Our next question is, where would you like to see pain care in rural areas go? Is there kind of a current trajectory? So whoever would like to start, I'll open it up.
Happy to start. I would love to see patients to be able to access care that is patient-centered, trauma-informed, evidence-informed, and is accessible regardless of where they live. I think we're on the way there. And as Lisa mentioned, there's been a lot of research and a lot of knowledge generated in the last 10 years. We're just starting to build on that knowledge to actually disseminate it and implement solutions that can deliver those services and that knowledge to patients where they are. And I hope we're on that trajectory with the Foundation of Primary Care Alberta as a provincial agency that supports primary care. And we know that a lot of chronic pain management happens in primary care, so having that support in primary care settings is super important. The ongoing transformation of the healthcare system and changes to the primary care networks in the future, hopefully we'll see that consistent care where patients can actually access care regardless of where they are. So I think we're on the way there, but it probably takes time, and it's very unfortunate that patients have to wait and experience those barriers now.
And I agree. I know I tend to be fairly optimistic, and there's certainly lots of challenges and a lot of work to do. But compared to, even just a few years ago, I do think we are moving in a positive direction. Congratulations on the award for the Virtual Pain Center. I'd heard about that, so that's fantastic. And I think that's one of the, an excellent example of what we can do and really to help increase access for people living with care. I also think beyond just the virtual pain program that there's just so many more resources available out there, both for healthcare providers, as we've talked to, but also people living with pain. There's resources such as Power Over Pain, Live Plan B+, online programs, Better Choices, Better Health. The disadvantages is that there's a lot of misinformation out there. So we do really have to work to help people obtain the skills to find and use this reliable information. And I think that's something that our primary care providers and really all healthcare resources can also improve on and tend to use these resources a little more effectively, not just, go have a look at this, but actually, prescribe some of the resources and say, okay, what did you think about those? And, how's that relevant and how can that help you? So the structured programs, but as well as just all the other resources that are available out there. So I think that's encouraging. As we've talked about, I think there's a lot more education for healthcare providers to keep current with pain. We've got the Pain Society of Alberta, Canadian Pain Society, International Association for the Study of Pain, lots of organizations now that are really working hard to disseminate the information. So I'm hoping that will help rural providers as well be a little bit more, or make it easier for them to stay current and perhaps create the interprofessional teams that are necessary as well. So I do think we're getting there. We need to be creative. Many programs are now hybrid, mixture of in-person, telephone, and virtual care, which can increase flexibility. We don't necessarily need to cancel everything for snow or storms or bad roads anymore, or add to the burden of travel, as you had mentioned too, for people that are already have a lot of challenges too. So I think that we're getting more support for pain education for both, and I also think we are slowly working towards more support for the healthcare providers in the rural areas, and that's always challenging, I know. But there's lots of people working very hard for that as well. So I think that's encouraging, and I think it's easier to create those community of practice and hopefully be a little less isolated than sometimes people tended to be before. So funding and access, of course, challenges, but as you said, I think we really are moving in the right direction for improving access, not based on where you live.
Yeah, absolutely. It definitely seems like it's going in a very positive trajectory, and yeah, you've both made immense progress towards that. So thank you very much. Thinking about the long-term future of pain or virtual pain care, would you see it as a bridge, a band-aid, or a long-term solution?
Want me to go first for this one?
Sure.
Bridge, band-aid, or long-term solution. Really, I think virtual pain care can be all three, depending on the situation. It can absolutely function as a bridge. I think that's a very good way to look at it in a lot of situations. So virtual care can help connect patients to education, support, and clinical guidance, while they're waiting for in-person services, or it can complement and extend in-person care between visits as well. So I do think it's a fantastic bridge. At times, it can certainly act as a bit of a band-aid, something we can use in more time-sensitive situations when perhaps access to in-person services is limited or you can't get there, those types of things. And in those cases, it may not solve every challenge, but it can still provide that meaningful support and help people get started. One example that pops up is just now is I think it's really helpful that a number of pain clinics do now offer virtual classes to people that are on the waiting list for services. And, that didn't happen a number of years ago. So, and as we talked about, there's also many excellent online resources and information sources that healthcare providers can refer their patients to while they are on some of these waiting lists or waiting for further services too. So I do think it can be a bit of a Band-Aid, even if that's not necessarily the ideal order. And I guess more broadly, I absolutely see virtual pain care as a really important long-term tool. It's certainly not going to replace all in-person services, not in any any plans, I don't think. But there's lots of situations where face-to-face assessment and palpation and care are essential. But I think research has shown that you can develop those therapeutic relationships, and you can deliver so many programs virtually that it's not just if we can't see you personally, we'll default to that. I think there's a lot of advantages over in-person services too. So I think it could be all three, and I'm kind of excited about that hybrid model.
Definitely, yeah, that's a really great answer. Thank you so much, Dr. Jasper.
Yeah, and I would tend to agree. Virtual care might have started as a bit of a band-aid in response to the urgent gaps, but right now it becomes a bridge and even an important pillar within that blended model of care. It definitely doesn't fit all the needs. It doesn't address all the needs. We can't cancel in-person care, but for many patients, it can be support now while they're waiting for other supports, or it could be the supports that they need, especially if it is more accessible for them. We also have to recognize that there are many people who are not comfortable with digital technologies, and unfortunately, virtual care often won't work for them. Having said that, we've had many patients who were hesitant or uncomfortable, and providing them supports with how to use that Zoom, how to access it, actually made them more comfortable receiving that care. We've also had patients who were not able to access resources digitally, so we would arrange care in telehealth settings or print the materials and send them to them because they can't access it on a computer. So having that flexibility and being mindful of the settings where the patient comes from and being as accommodating as you can, I think is really important. So virtual care can be very helpful. Definitely doesn't replace everything, but I think there's opportunities to leverage different settings and different ways of delivering care so that we provide care to as many patients as possible.
Thank you so much. Yeah, it's really great that there's that flexibility and accommodation as well. And I guess this kind of goes into our next question about equitable pain care. So as far as equitable pain care, what would you say that actually means in the context of rural Alberta?
I think to me, it means that where the person lives or where the person comes from, what is the background of that patient, the characteristics, they don't define the quality of care that they get. So that any patients, regardless of any of those criteria and factors, is able to access care that they deserve and that they need. So reducing that travel time when needed, ensuring that care is culturally safe and appropriate for many populations, ensuring that it's patient-centered and trauma-informed, that patients feel heard and respected, that they can access multidisciplinary care. That all should be important and should be accessible to them regardless, to make it equitable and actually patient-centered.
Yes, I agree with everything you said. Absolutely. It doesn't have to be based on your characteristics to determine what care you get. And I think it's interesting when we talk about equitable care, that it's important to remember that equitable doesn't necessarily mean equal or the same. And we had these discussions all the time when we were providing education at different locations too. So equivalent does not mean the same, and providing the exact same service everywhere doesn't always lead to good outcomes, and that's not actually often the best the best plan. So I really like what you had said too, about the all the different ways that we can use virtual care in a spectrum, and even for people that aren't necessarily familiar with virtual care or want that, helping them become comfortable, whether it's with the help of a grandchild or just a telephone visit, or helping them set up the Zoom and mailing the paper copies out to them. And it just gives us a really wide it increases our access and increases the choice of tools we have so that equitable pain care can look different in different situations. So everybody, as you said, 100% has access to the care they need, but it can look very differently depending on their specific situations.
Thank you so much. Yeah, I think you both raised a lot of really great points and great examples of how that might look different from patient to patient. Yeah, we're actually coming up to our last question now, so we appreciate all your time and all your thoughtful inputs to this discussion. Our last question here is, what advice would you give to trainees who might be interested in rural pain medicine?
I can jump in. I would say go for it, 100%. If someone, honestly, if somebody told me that I would be in this field and, teaching and working and researching in the area of chronic pain when I first graduated, I would not have believed them. But I have no regrets. So I feel that you're going to work with people living with chronic pain, whether you choose to or not. And, the 1 in 5 people. And that's what people come to their healthcare providers for. So when pain's affecting their lives. So we are going to be working with people with chronic pain, whether that's your specific area of practice or not. So it is important for everyone to have that solid understanding of chronic pain. And then I also just think it's one of the most exciting areas of practice out there. Completely biased, of course, but our understanding of pain is evolving so quickly that there's so many more tools we have to offer people that we just didn't even 5 years ago, certainly not 10 years ago. When I looked at what my master's research was and the questions we were asking, I mean, that's just a given now. That's not even begin to think of questioning the role of, the cells that we're looking at and so forth. So it's a very exciting area of practice. We're now, I think, just approaching the time where we're really getting more successful in moving that knowledge into practice. So I think it's exciting time for it. And of course, as you can probably tell, I'm a very strong supporter of rural practice. Absolutely, there are challenges, but I've also seen incredible innovation and collaboration and commitment from rural healthcare providers and teams. I think rural clinicians are often really good at recognizing needs and finding creative ways to meet them and really just getting it done and in a really practical way too. Because communities are smaller, providers often know each other and they can work together maybe more easily, which can make building those interdisciplinary teams maybe a little bit more effectively as well. Other advice, I guess, I think it's really important to really spend the time to build your network and your support systems too. So find your people, your resources, your organizations, whether it's informal or formal, create those teams. Maybe just be someone that has an interest in pain and that you feel comfortable referring to, or who you can ask questions, where you can learn from, who can support you too, because all our jobs can be somewhat isolating. Never mind rural, never mind the challenges of pain care too. So I do think that's important as well. So yeah, I think it's a fascinating, evolving, meaningful area of practice that I certainly would strongly recommend.
Yes, I think a lot has been already said, and the main point is go for it, because we need really good healthcare providers in all settings, and in particular in rural settings. It might be challenging, but it is also very rewarding. And when we were co-designing the virtual pain program, this is exactly what we heard. As Lisa said, in rural settings, often providers are able to come up with those creative solutions and overcome the barriers between different organizations or different departments to actually make the system work. And I think it's excellent and just shows the brilliant minds that we have in our healthcare system. And it includes physicians, but it also includes nurses, allied healthcare professionals. Chronic pain management requires that multidisciplinary approach. I know it's often challenging in rural settings, but we need diverse range of providers who are able to work together, collaborate, and work in multidisciplinary settings. And also who are able to listen to patients and communities. I think it's really important. A lot of solutions can actually come from the patients, and understanding their needs and their challenges and the barriers that they experience, I think, is often very important to ensuring that the care that's delivered is patient-centered.
Thank you both so much. Yeah, really exciting area of research and I can imagine how rewarding it is seeing the challenges that you can overcome and make a really significant difference in patients' lives. That actually brings us to the end of our panel discussion. So maybe what we'll do is stop the recording here, and then we can open it up. If anyone else in the audience has